Okay, I wanted to do this video on hepatology and liver cirrhosis and acute viral hepatitis and all of that. It's very high yield. And so basically liver tissue architecture. Okay, so this is the portal vein and you have these hepatic triads. So to understand, and they have three zones: zone 1, zone 2 and zone 3. Zone 1 is the periportal zone, and zone 2 is the intermediate zone, and zone 3 is the pericentral or centrilobular. Okay, so here this is how it looks. This is a liver, and this is the portal triad. Portal triad consists of hepatic artery, portal vein and bile. Okay, it has a countercurrent exchanger like flow. So what happens is hepatic artery comes, generates the pulse to push the blood forward, and the portal vein comes from the GI tract, from the small intestine, large intestine, and they both meet here, and they move forward into the central vein. So this is the central vein. Now zone 1 is periportal, so it's in the direction of flow. So this is zone 1, this is zone 2, and this is zone 3. Okay, now zone 1 is affected first by viral hepatitis. So zone 1 is where all viruses which come from the GI tract or the bloodstream come and sit and affect zone 1. Zone 2 is the intermediate zone and is affected by yellow fever, and zone 3 is affected by ischemia, which is obvious because the blood flow is going that way, and it is most sensitive to metabolic toxins such as ethanol, halothane, rifampicin. So basically the P450 enzymes are in the central zone. So you have to remember the flow of blood, and then you have the apical surfaces and you have the basal surfaces, and the here you can see this is the bile. So the apical surfaces of the hepatocytes face the bile caniculi. So this is the apical surface, and the basal surface of the hepatocytes face the sinusoids, which is the hepatic sinusoids that we usually see. So we have the basal surface and the apical surface, and this is where the bile flows, and the UDP glucuronide transferase conjugates bile and secretes bile into the thing via the rotor pump. And so basically so now once you get this clear, we can quickly run through various forms of hepatitis and the important things. So we have different types of viruses which affect the liver, and they are basically these viruses that you can see here. That's hepatitis A, which is fecal-oral route, and hepatitis E, which is fecal-oral route. This is the most common hepatitis in India. In India, it's the most common hepatitis. In India, hepatitis E. Now, hepatitis C always goes into chronic hepatitis and goes into cirrhosis and carcinoma and cryoglobulinemia. Okay, but hepatitis B, it causes membranous glomerulonephritis. It is parenteral in the blood, bedroom, and birthing. And hepatitis A is acute and self-limiting. That's hepatitis A. Hepatitis D is a super infection where hepatitis D, co-infection of hepatitis D with hepatitis B happens. So here you have these following viruses: hepatitis A, hepatitis B, hepatitis C, and hepatitis D, and hepatitis E. So the incubation period of hepatitis A is short, it's self-limiting, you don't really need to treat it, and it goes away by itself. That's the same thing for hepatitis E. Now, how do you manage hepatitis B and hepatitis C? And what are the pathological findings you see? So basically, in hepatitis A, if you take a liver biopsy, you just see a hepatic swelling, and you see these councilment bodies, which are like this swollen pink counseling cells, like councilment bodies. And in hepatitis B, you will see granular, not clear, but granular eosinophilic ground glass appearance due to accumulation of surface antigen within infected hepatocytes. So that's what the granularity of hepatitis B virus indicates. And hepatitis C will show lymphoid aggregates because it's chronic inflammation and patchy necrosis. Hepatitis E can cause necrosis of fulminant hepatitis. Carrier state is very common in hepatitis C, and hepatitis D depends on hepatitis B. Hepatitis E is enteric. So you can have various extra hepatic manifestations of each of these. In hepatitis B, you can have aplastic anemia membranous and polyarteritis nodosa. Here you can have porphyria cutaneatida, lichen planus, which is very common, leukocytoclastic vasculitis, membranoproliferative is more common, cryoglobulinemia is more common. So what are the serological markers? So basically, first you need to look at the infection over here. First, the body gets infected with hepatitis B, and then hepatitis B has the surface antigen HBs AG. That's the surface antigen. This is also injected into the body with a vaccine, but that is different. We will talk about that. But right now, this is the virus. It has entered the body. The virus starts multiplying. It's a DNA-based virus, and what happens here is within months to exposure, up to within 3 months, this hepatitis B or HBs AG particle will peak. Then what happens? You have a window period where antibodies have started forming after 6 months, IgG predominantly antibodies, and here what happens? You get anti-HBs. So that is positive even in vaccines. But now how do you differentiate between a vaccine and a true infection? So now the virus has other two things. It has a core antigen, but you can't detect the core antigen. You can detect an antibody to the core antigen, that is anti-HBC. So that is positive in the window period over here. So that is in the window period. You can get anti-HBC. Okay, and here onwards, you get anti-HBC positive over here. This means it's a true infection, anti-HBC. And if it is fulminant, if it is a fulminant hepatitis, you will have HBe antigen positive. So HBe indicates active replication, and then anti-HBe is the goal of treatment or goal of response. So now if you have a patient that comes to you with hepatitis and you have an anti-HBe, it means you have already won the battle. You've already cured the patient. If you have a patient with anti-HBsAg, it means the patient is either vaccinated or recovered. Now, how do you know if it's vaccinated or recovered? Now, if it is vaccinated, you will have only HBsAg. But if it is recovered, you will also have anti-HBc. So anti-HBc is what gives us the thing of previous infection. So if you see over here, anti-HBc, antibody to HBsAg, IgM, acute or recurrent infection, IgG prior exposure. So that's the only way, anti-HBc. So that is what it is. Anti-HBc will always resolve your confusion if it is a case of hepatitis in that case. And anti-HBe it indicates low transmittability. HBe is secreted by the infected hepatocyte, and it indicates that. So now basically we have already approached the serology and approach to these various hepatitis viruses. Now we know that you have this granular eosinophilic ground glass appearance in hepatitis B. You have Councilman bodies in hepatitis A. You have Mallory bodies in alcoholic in alcoholic liver disease. So basically, what is Mallory bodies? This is what Mallory body is. So you see the hepatocyte here, and you see this keratin particles here. That is a Mallory dropout, cytoplasmic inclusion of damaged keratin, which indicates that it is an alcoholic hepatitis. In alcoholic hepatitis, you follow these following stages. First, you have hepatic steatosis, and then you have acute alcoholic hepatitis, and then it goes into full-blown alcoholic cirrhosis. So dropout Mallory bodies are there. What happens is, why do you have this? Because basically when you drink a lot of alcohol, it depletes nutrients, you deplete vitamin B12, and methionine and SAM basically go, and you it's basically, you see, when you drink alcohol, you have increased NADH and you have decreased NAD. So that itself changes the metabolic state of the body, NAD and NADH ratio. So body oxidizes during breakdown. So basically glutathione is what eats away all the free radicals in the body. The body anabolism or in reduced state, NADPH, goes everywhere and keeps the body in a reduced state. Now when you drink alcohol, you increase this reduced state because you have depleted all the glutathione, and the body is in an excessively reduced state, so it does not go into catabolism. Catabolism is in an oxidized state, so when you are like breaking down things, you'll have more NAD plus. So alcohol will put the body in a perpetual reduced state, so it decreases the metabolism, and it puts it into an anabolic into an anabolic state. So macrovesicles deplete SAM, increase SAH, and then that's what causes cirrhosis in the liver. Now, course of liver disease, you have chronic liver disease, compensated cirrhosis, decompensated cirrhosis, and death. Okay, and now that is acute hepatitis. Now, if we go to chronic hepatitis, we have chronic hepatitis B and chronic hepatitis C. So, what is the treatment recommendations? So, treatment recommendations for chronic hepatitis I will be covering in the next video.